Hey all, welcome back to the Real Life Pharmacology Podcast. Thanks so much for listening today. I'm your host, Eric Christensen. I am a pharmacist and I primarily work in geriatrics, and that's what I'm going to share a little bit about today. Really going to cover some polypharmacy cases and examples. This is part two of two, I guess, if you will. I just jotted down some recent examples I had seen in practice over the last 3 to 6 months, and just wanted to share those examples with you because this is stuff that I see on a fairly regular basis. So before I get into that, reminder, I've got the geriatric review course at meded101.com/store, geared towards pharmacists, but again, anybody could definitely benefit from that if you're looking for more pharmacology, pharmacotherapy type of education. Got stuff on other board certifications as well for pharmacists, BCPS, ambulatory care, geriatrics, BCMTMS, lots of good stuff at meded101.com/store. So go check that out. In relation to this podcast episode, I do have a book called Perils of Polypharmacy on Amazon. It's received a lot of really kind and nice reviews over time. Definitely a great resource if you're working in geriatrics, learning how to identify medications that we can reduce, recognizing cases and situations, and really just honing in your focus on polypharmacy, deprescribing, and how to improve the lives of our patients and make medication regimens more simple. Okay, so again, go check that out on Amazon, Perils of Polypharmacy. All right, let's get into the examples that I wanted to cover today. First one is opioids. So many situations, cases, I deal with a ton of rehab patients over time, and these patients get put on scheduled opioids. Usually it's in the short term for a week or two. You know, they had knee surgery, hip replacement, hip fracture, so on and so forth. They had a surgery of some sort, and obviously that's going to lead to significant amounts of pain, and many patients will need short-term pain relief. And we use opioids frequently, hydrocodone, oxycodone, morphine. I see those medications all the time. And when we use those medications on a frequent basis, we are going to run into constipation in the majority of cases. And we appropriately add laxatives, Miralax, Senna, those type of medications. But I will say it gets missed more often than I would like to say or admit, where the laxative medications hang on board. So, we do a great job treating the acute pain. Now we're, tapering down, getting them off of opioids, chronic use, and now the laxatives remain on board. We forget about them. 2 weeks, 4 weeks later, maybe the patient, maybe a nursing professional taking care of that patient says, hey, they're having a lot of diarrhea. They send a fax or they call the doc, and it's like, okay, just take some loperamide for a few days. And it's like, the loperamide, resolves the problem. It helps, bind them up a little bit more so they're a little more solid in their bowel movements. But now we're taking a laxative with an anti-diarrheal medication. It makes absolutely no sense. It contributes to polypharmacy, increase the risk of adverse effects, and so on and so forth. So really pay attention to that when we appropriately treat pain and we appropriately get them off their opioid medications after surgery or whatever the case may be. Pay attention to the laxative regimen, okay? If they didn't need laxatives before the opioids, they probably don't need laxatives after the opioids, okay? Really, really pay attention to that one. It can definitely help prevent problems in the future. All right, next situation I have seen recently. I had a patient taking chronic loop diuretic, so I believe it was furosemide 40 milligrams daily. They had heart failure. They also had a history of trigeminal neuralgia, and they were taking carbamazepine. And they had a history of depression, and they were put on an SSRI, I believe it was sertraline in this situation. That led to significant hyponatremia. so low sodium levels, which led to the prescribing of oral sodium supplements, basically, to try to keep that sodium level up, which obviously in the balance of heart failure, that can cause some complications there as well. So really knowing, understanding side effect profiles, recognizing that carbamazepine and SSRIs in combination really increase the risk of SIADH, and having it on top of diuretic therapy can definitely lower those sodium levels. So pay attention to that. What I would do is I would look for alternatives where they're available. If they need that loop diuretic for heart failure, I mean that kind of is what it is. However, reassessing carbamazepine, has that been helpful? Are we at the minimum effective dose? And then if we've recently added an SSRI for depression, look to alternatives. Are there other meds that may work for this patient just as well? Look at mirtazapine, look at bupropion, for example, maybe a little lower risk of SIADH and low sodium levels. So again, looking for alternatives and obviously addressing that hyponatremia as best as we can. All right, next example is something I definitely come across periodically. Corticosteroids, specifically systemic corticosteroids, whether that be for a significant rash, whether that be for pneumonia, COPD, asthma, respiratory disorder. Corticosteroids are used for a lot of different things, and certainly pain syndromes as well. Rheumatoid arthritis flare, for example. Well, I've seen numerous cases of this causing significant hyperglycemia, particularly in diabetes patients where we're monitoring blood sugar closely. And that can lead to obviously adding more diabetes medications, which, ultimately they all have their own side effect profile as well. But it can also lead to the risk of hypoglycemia potentially afterwards. So if you've got a patient on insulin, and because of the corticosteroid, maybe for a week, 2 weeks, whatever we're giving that for, we escalate insulin therapy, or maybe they're on a sulfonylurea and we increase that dose. Now, when that corticosteroid goes away, those blood sugars could kind of fall back into their normal range, and maybe that elevated dose of insulin or that elevated dose of sulfonylurea is too much, and now we cause hypoglycemia. So when you've got patients that are taking corticosteroids, it's a new burst of corticosteroid, I guess, if you will. Be sure to recognize the change in blood sugar that's going to happen, or very likely to happen, with the addition of that prednisone, for example. Pay attention to that and recognize that when we start it, we may have to adjust diabetes meds and monitor more closely. And when we adjust the dose and or take away the corticosteroid as well. Really important principles there to remember that with the use of corticosteroids. All right, another example, metoclopramide, not a medication I see used terribly often anymore, but this medication can be used for nausea symptoms. You may see it used for gastroparesis, kind of that slowing down of the gut. And in this situation, I saw metoclopramide be started in not an ideal patient population. It was a patient with Parkinson's disease, and it has dopamine blocking activity. And remember, any medication that has dopamine blocking activity can exacerbate Parkinson's disease and cause movement disorders and movement type adverse effects. Okay, so really, really important to remember that. And metoclopramide, again, has dopamine blocking activity. And in Parkinson's, we try to give more dopamine to help with the motor symptoms associated with that disease. So again, metoclopramide was added. We had worsening Parkinson's symptoms. That caused an escalation of the dose of Sinemet that the patient was taking. Okay, what I would do in this situation is look for an alternative to metoclopramide. If we're we're talking nausea, for example, we've got plenty of alternatives out there. Ondansetron probably being the most commonly used medication I see there. So again, looking for alternatives there, and hopefully that would allow us to get that patient back down to their standard Sinemet dose that they're on. All right, last example I wanted to touch on here is the use of anticholinergics like diphenhydramine for sleep. This is something I've seen quite a bit and don't love it. Anticholinergic effects are problematic in geriatric patients. I would say the most common adverse effect I see with anticholinergic medications leading to polypharmacy is probably constipation. So kind of that similar mindset of opioids. When you see a new anticholinergic medication being added, like diphenhydramine for sleep, or if you're working outpatient and that patient just starts taking that on their own, or they take Unisom or whatever brand name PM medication, those most often have an anticholinergic type medication in there. Okay. So constipation, definitely something I see quite a bit. And obviously the patient is going to try to take, laxatives and those type of things to treat that. Hopefully we can find an alternative to the anticholinergic, or hopefully we can encourage, better sleep hygiene and things of that nature to avoid that. But I've also seen plenty of other cases involving anticholinergics, worsening cognition and adding, a dementia medication, for example. I've seen worsening urinary retention, leading to the prescription of BPH type medications. That's another classic anticholinergic example. Dry mouth and dry eyes. You can see saliva substitutes. You can also see artificial tears. Tons and tons of examples that you should be aware of and memorize in relation to anticholinergics. They can really cause some problems when it comes to the prescribing cascade and polypharmacy. You can see I listed off 4 or 5 different disease states and conditions that anticholinergics can worsen. So super, super important to pay attention to that whenever a new one is started. And be aware of some of those red flag new start medications that may be indicative of one of the adverse effects of an anticholinergic medication. All right, well, that's going to wrap up this podcast for today. Do me a huge favor, support the sponsor, meded101.com/store. Tons of resources for pharmacists, nurses, healthcare professionals. All those links are listed at meded101.com/store. So go check that out. Your support there directly helps fund this podcast. As always, take advantage of the Real Life Pharmacology free giveaway. It's a top 200 study guide, 31-page PDF, absolutely no cost to you. Simply an email will get you access. And then obviously we give you updates when we've got new content and other things available as well. If you want to reach out to me, comments, suggestions, mededucation101@gmail.com. Or you can track me down and connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. One last favor I always ask you guys, if you've got friends, colleagues, students, people you work with, healthcare professionals, you want to share pharmacology education with them, please share the podcast. Help educate, inform healthcare professionals about medications. That's my ultimate goal with this podcast, is to help as many people learn pharmacology and medication safety as I can. So again, please email listservs, classmates, all that good stuff. Please feel free to share the podcast as much as you can. I greatly appreciated that. With that, I'm going to sign off for today. Thank you so much for listening. Take care. Hope you have a great rest of your day.